And thank you, B.K. Shruti ma'am and sir, for a great introduction to the subject. Now we'll quickly deep dive into some of the discussions of this subject. I think this area is really evolved well, and one of the things that one cannot outline enough is the need to understand which particular alteration we are dealing with, whether we are dealing with driver mutation, whether we are in the realm of non-driver, non-small cell lung cancer. Today, adenocarcinoma lung, advanced adenocarcinoma lung is categorized in very different forms, and it's extremely critical to understand what exactly we are facing and what therapy to design for our patients. With that, I will start the moderation, and thank you for introducing my panelists for the evening. I'm sorry, I'm just going to project my slides in 1 second. So we have Dr. Ashish Singh and we have Dr. Krupa Shankar, and we'll just go ahead with the discussions, wherein one of the most prominent discussions is whether we are looking at treating our non-small cell lung cancer patients with nuances, specifically when we are talking about EGFR mutants. So we heard the introduction, we also heard the talk with B.K. Shruti ma'am. In context of that, I present a case, a 57-year-old female was diagnosed with stage 4 adenocarcinoma lung. She's diabetic. A PET scan shows metastatic sites starting from the right upper lobe in the lung, liver, mediastinal lymph nodes, and classic symptoms: cough, dyspnea, anorexia, weight loss, PS of 1. What further testing methodology do you routinely prefer in your clinical practice? And essentially, what is your testing at the doorstep? I spoke at one of the other meetings last evening, and again, this is a hot topic right now. What would you do? Would you do a small panel? Would you do a bigger panel? How would you look for your driver in this context? So either one of you, please deep dive. Ashish and Dr. Krupa Shankar, please.
Yes, so ma'am, I work in a tertiary care teaching center. So our first reflex testing would be an EGFR PCR and ALK and PDL1 and IHC and sometimes even ROS. And so that's like, that functions as a good screening test. And subsequently, if we don't find anything here, we go for either a lung specific panel or a larger panel.
Okay, very good. And any other thoughts?
I think I work in a corporate sector as well, ma'am. So I would probably look at doing it the other way around, because sometimes you can run out of tissue as well, and tissue has always been an issue for us. So I think, probably if the patient does not have any financial constraints, I would definitely look at doing a broad-based NGS right up front.
Okay, wonderful. So there are different practices, I think, where we work and what are the facilities. It always has an impact to how we.
I think one of the biggest challenges is the turnaround time. Time with NGS, and which you just can't beat PCR with that. So yeah. that I think is one of the advantages, especially if because patients want treatment fast. So.
Sure. Yeah, and you also want to treat them many times. These patients come quite late, and so we are also in a rush and we want to start therapy right away. Having said that, even then there are differences in styles of what we are able to test for at the entry point. So then question comes in whether we wait for the results, and as you said, sometimes when we are pressed for time, we are not able to wait for the results. One of the basic questions: do you routinely do a brain MRI for all your stage 4s unless the patient is symptomatic? Of course, if the patient is symptomatic, you will do, but do you do it as a screening for asymptomatic patients if they have advanced disease? And when do you do it? Either one of you.
So I think if you would ask me this question 2 years ago, I would have said I don't routinely do it. But now, especially with when we have to choose therapies based on CNS penetration, and also if there is somebody with large volume disease, we very often we find almost 20-30% of times we find asymptomatic brain metastasis. So I'm increasingly doing it, but if you ask me, do I routinely order on day one? I don't.
Okay. Okay. That is also a style that varies between institutions, and it could be practiced in a certain way at a corporate center versus a teaching center. And I think those are nuances. As long as we pick up and we understand that the brain needs to be scanned, and we do it in right time, I think we are fair. So NGS here shows variant EGFR L858R mutation, which is pathogenic, obviously, and a PD-L1 expression that is high. So I guess the point that we are trying to make is when you have a driver mutation and you have high PD-L1, what do you choose? And are all EGFR mutations similar, or do we think of them as different? And we heard from the introduction as well as our previous speaker, B.K. Shruti ma'am. And so your thoughts on these, mainly before we move to the next points.
So I think in the presence of a driver mutation, I think we can conveniently disregard the PD-1 expression. It really doesn't make any difference to us whether it's 50% or even 90%. I think we look at targeting the driver mutation, obviously. So I think that's my take on it. Look at targeting the driver mutation, definitely.
Excellent. And yours, Ashish?
Yeah, so we found this increasingly that these EGFR ALK, they're very often PD-L1 positive and sometimes to a high degree positive. So at least I go by, if you look at all immunotherapy trials, they would exclude EGFR and ALK. So in that we are very clear, but what if this has a BRAF mutation and PD-L1 positive? So that I don't think then I can't apply this rule over there. So at least for this EGFR sake, it's very clear we have to disregard that. Now, your next question you had was, is there any difference between the way we look at these mutations? Now, we're increasingly seeing this, not only with the osimertinib data, but also with the afatinib data and other TKIs data, that they behave differently, and maybe it has something to do with the drug binding the receptor sites or the domains, and so therefore we know that the efficacy is not as great with L858R, with whatever we have, even including osimertinib, as compared to the first and second generation drugs, and what we've been seeing this evening is that VEGF inhibition, because it doesn't depend on the tumor per se, because we're acting on tumor microenvironment, is active irrespective of the kind of mutation you carry.
Great, I think great points. I also agree that we have enough data. We were short of this, I would say, around 4 or 5 years ago, but we have enough data today and evolving more in this area where it's become much more clearer that a PD-L1 high in a driver mutation positive person, or a typical phenotype where you would think of a driver mutation positive person, jumping on the Keynote 189 regimen is not appropriate. One has to really do a close check of what we are dealing with. This has been the theme of one of the themes or prominent themes of this meeting, and also what you just said, wherein different EGFR mutations are now being recognized to behave differently, and you cannot put them all in the same bracket. And I feel that it's become much more important for us to start distinguishing that, because if I tend to forget and I move on, the bad behaving one, the guy who will fail sooner, or the lady who will fail sooner on single agent TKI up front, and I've gone back and looked immediately, a lot of times that has been L858R, and that just goes without saying how these alterations are all distinguished. They're different. We really need to understand how different they are, and consider treating them differently as well. So one of the questions that we have here is if we have all these different kinds of mutations, as you see, exon 19, exon 21, uncommon EGFR mutations, and exon 20 insertions, do we think of them upfront in a different way are they equal or are they different in the clinical behavior for our patients? And so I think I've heard from all of you all that we take them as different. And here the slide was shown earlier, and I can't reiterate enough that if you compare the behavior of 19 versus 21, the results are significantly different, and it's about time that we woke up and understood that this kind of results were seen in multiple trials, even in the meta-analysis. And we have the results out here where significant reduced risk of disease progression for exon 19 versus L858R, as just was said. And again, similar theme here, showing different trials and hazard ratios with advantage to exon 19 versus L858R, and progression risk being lower in 19 and higher in L858R. And when we go to the L858R and L19 and the overall responses that were seen and in the intent to treat population, again, same theme, where the benefits in all across, when you look at the PR, the stable disease, the response rates and the disease control rates, the highest disease control rate being in the exon 19. So coming back to the panel, in your clinic, when you see these numbers, does this really bring you to think that these patients should be treated differently? What is your clinical take on these slides that were just seen and this particular slide as well?
So I think definitely yes. In clinical practice, you really need to make that distinction. And for example, like the exon 20S768I mutation happens quite frequently if you have an L858R as well. And that's where I think probably an NGS comes in, because by checking for your regular EGFR on PCR, it doesn't pick it up. So you'll need to probably opt for an NGS if you're looking at your other concomitant mutations as well, which can actually predict for poorer outcomes and also for lesser responses from your regular TKIs. But having said that, I'm not sure if only VEGF inhibition is the answer, because if you look at the Archer 1050 data as well, even in the exon 21 L858R, the magnitude of benefit seems to be preserved with dacometinib. So that seems to be another option as well. So definitely, yes, we'll have to look at concomitant mutations as well, because that predicts for a poorer survival and also the outcomes, and also the response rates seem to be worse off. So, yeah.
Great. So have you, and Ashish can take this, have you seen in your clinical practice the co-mutation rates are higher for the L858R, or is this once removed observation for this particular retrospective data?
Yes, ma'am. I think, as you said, we all have beginning to see that these patients are doing poorly, and we have to understand why they are doing poorly. Is it because our drugs are not designed to be very effective, or is it that they're doing poorly because of other coexisting mutations which we're not picking up because our PCRs are not designed to pick those up? So that is something, one thing in terms of trying to understand why they're poorly. And other thing is, when we're choosing treatment, when I have an L858R, those curves on the screen would tell me that it won't be within less than a year they'll probably be progressing, and even with the best drug osimertinib we have, the PFS is not very great. So that is where I would want to intensify my treatment upfront, knowing that in lung cancer not many will go on to second line. And that's where adding something to a TKI, which is either bevacizumab or even chemotherapy based on our Indian data, or choosing like a pan inhibitory TKI or irreversible TKI, what Dr. Kripa was mentioning, is an option. However, toxicity and everything put together, if you look at all the three options we've got, ramucirumab has the best toxicity profile, and it's very well tolerated. So why not? And a 7-month gain in PFS is something which we can't ignore.
Absolutely. I think that's a point very well made. I think we need to understand why these patients don't do well and what would we give to jump that hoop. Because blindly today, I think we have enough data now to generalize, right? So we have enough data to say these two are different. And if we know that they are different, what makes them different? What all are there? What things are there that need to be addressed differently? And one is obviously co-mutation rates. And so what do you do for co-mutation? I agree with what both of you have just said, that single agent TKI does appear less treatment at this juncture, wherein you are suspecting so many other things to happen. And that's where I think question of adding something to the TKI comes in, and the Tata data with TKI plus chemotherapy being one. And in terms of tolerability, of course, the current study that was discussed where erlotinib plus ramucirumab combination comes into the front and center. So for this patient coming back, do we give erlotinib, gefitinib, afatinib, dacomitinib, osimertinib, ramucirumab plus erlotinib, chemotherapy plus gefitinib? One of the best parts of this kind of a discussion is that today we have so many options, and that's a luxury. Goes without saying. 10 years ago, we couldn't talk this way at all. So for this patient, what would we do? We have a lot of data with combination treatment where we have, actually this data is looking at single agent TKI versus chemotherapy, and then TKI versus TKI. And we all know the FLORA data. We also know the Tata study where we gave gefitinib plus chemotherapy. And we also know the Archer study, dacomitinib versus gefitinib, and the benefits associated, and all the Lux lung studies with the afatinib. So coming in here for this patient, when you look at the combination regimen of relay with erlotinib plus ramucirumab and the benefit, it truly stands out in comparison to any other trial as well. And one of the most remarkable things is benefit in the L858R alteration. So going by that, if you think about a particular patient who's presenting to you with exon 19 versus L858R, in your clinical practice, what do you choose today? I mean, you have it in front of you right now, wherein you're seeing exon 19. This is a very frequently visited slide, exon 19 versus L858R. And you have the numbers in terms of what FLORA did, what Archer did, and what we have for relay. So thoughts on that from both of you?
So yeah, so I think I'm actually waiting for data where patients actually get randomized between exon 19 versus 21. Because unfortunately, we are still relying on only subgroup analysis, be it either exploratory or pre-specified as well. So I think that it will be really interesting to have a trial design looking at only patients with exon 21 versus exon 19 and see if that actually turns out. I think that'd be really interesting. But coming back to your question, I don't know why the erlotinib plus bevacizumab, because we have data for that as well, and it's not just the NEGS study, but also we have data from the Beverly study, which was another phase 3 study looking at erlotinib plus bevacizumab, and that also the data, if you look at even patients with exon 19 deletion, seems to be as opposed to exon 21 L858R as well, the magnitude of benefit seems to be preserved in both the subsets. So I think, combinations probably would be a better way forward as far as exon 21 L858R. And the type of combination would probably depend on how deep the patient's pocket is.
Yes.
Yeah, I guess so. Yes.
So for me, I think I look at it like a relay race. So it's not that you have only one runner. You'll probably, the winner will probably be decided by the second as well as the third runner. So if there is a patient who really has bad disease and CNS disease and unable, which I think he will not go into the second line, then maybe osimertinib is the winner there because we have some overall survival data. But for all the other situation, like in exon 19 alone, we even know afatinib did little better than gefitinib from the Lux trials. So there again, if someone has low volume disease, I'm pretty comfortable with just afatinib. But when it comes to L858R and when it comes to, either kind of patients, less for low volume or high volume disease, that's where I would probably go with combination. And And for this patient, we discussed toxicity and everything else. And if the patient can access ramucirumab, that's the best combination we can go for. If finance is an issue, then combining with chemotherapy is what I'll do.
Great, great. I think those are the choices that we have to make as an oncologist in clinical practice. And I think today we understand that this behavior is different. We understand that this is the regimen that could help with this particular finding alteration. But we have to make our choices based on what the patient's logistics are, both in terms of the payment as well as travel and what have you, the other things involved. So this slide again shows how when we use the relay regimen, it eliminates what you're using. It eliminates the difference between exon 19 and 21 with what you're using. And that to me is a pointer in itself, where it's able to tell me that if I were to utilize this combination regimen, my patient will behave in the same way as exon 19, and that's a big win. So if we had different scenarios, would we be doing different things? And that's where this slide comes in, where it's actually interesting that it's exon 19, exon 21, exon 19 plus T790M. There's brain metastasis. There's exon 19 with no brain metastasis, and exon 20 insertion, which is another, which brings in another angle as well. So I think today the treatment has to be designed in a very, very nuanced way, and we cannot generalize the EGFRs, the so-called EGFRs anymore. So basic question, any role of immunotherapy for an EGFR mutant non-small cell lung cancer patient, and any thoughts or personal experiences with patients for either one of you?
So personally, I don't have too much of an experience, because when you look at the response rates, they are disappointing. And then with more robust drugs available in first and second line, and sometimes even if you add chemotherapy, we have another line. So I would say that we can't totally ignore these drugs, because we've seen some small subset analysis from the ABCP data. And responses in this range is also meaningful for some patients, but only in later lines.
Yeah, agree with that. And any other thoughts, Krupa?
I definitely agree with that, ma'am. I think, like Ashish rightly pointed out, the IMPA 150 study, the subgroup analysis, that's the only data that we have as far as EGFR positive patients and role of immunotherapy is concerned. So I would probably look at sequencing it with chemo and then looking at doing immunotherapy later in the later lines. So, agreed.
Great thoughts. So we have the MK study open here, and I can tell you a great degree of hesitancy in offering the EGFR mutant patients single agent immunotherapy even later on, because if the patient progresses, you have volume of progression, and you know that...
Hello, you have 2 minutes to wind over. We are
Yeah,
running out of time.
Sure. So that this patient is not going to have a magical response because of what we know about how the driver mutation patients behave. And here we have multiple trials looking at this angle, and actually very limited benefit. Also the bottom line that severe IRAEs could develop after TKI utilization. I have a patient right now with very bad pneumonitis. Several months post osimertinib, the immunotherapy utilization has led to significant pneumonitis. I've had another patient with pneumonitis and hepatitis. So word of caution, we're utilizing immunotherapy for these patients, and very important to keep that. So do you see concomitant mutations? I think we already said we see concomitant mutations, and what are the most frequent ones? So I'll get your final thoughts and then complete this panel discussion. You've already mentioned, I think Ashish mentioned this earlier, that you see concomitant mutations along with L858R. What are the common ones, and do you feel that these are responsible for the notorious behavior of L858R? Krupa and Ashish, both just chip in.
Yeah.
wrap
So
up.
yeah, I think I mean, like I've had quite a few patients actually with the exon 20 S768R mutation. Especially coexisting with the L858R. So I've had that, and apart from that, the P53, as you've shown up, RB as well. So especially loss of function of all these mutations. So we've had that in practice as well. And what we've seen is those patients actually don't tend to do as well as the others. I mean, like without any concomitant mutation. So that's how I would look at it, ma'am.
Yeah, so I mean, I agree. As I was saying, that we need to understand why
Right.
these patients don't do well, and also we need to understand, like, my guess is something like TP53 would be present at baseline, but as patients are treated, they develop new mutations, and a repeat biopsy may throw up some newer mutations, and in that situation, would you want to bring these combination even in little later lines is something which we all have to think about.
Yeah. So my 2 cents to this would be in agreement with what you all have said, and the only other thing that I understand is, again, just like eliminating the difference between exons 19 and 21. If you have equal representation, and if you are still able to lead to similar kind of responses even in presence of P53 mutation, that in itself is a win. And P53 is not the only bad behaving alteration in co-mutations when we talk about co-mutations for these patients, but it is one of the prominent ones. And so when you give the relay regimen, it takes care partly of this as well, and that just is a win for the regimen, and goes without saying that it helps the patients balance off the notorious effect of this kind of co-mutation that we see in these patients. So I think we have driven our point home, wherein we have said these two mutations behave differently. We've also said it's about time that we factored our clinical trials in a way where we actually randomized them to different arms and treated them differently. And finally, more than a single agent TKI is the writing on the wall for L858R and co-mutations and those that are P53 positive, and really brings to fore that it's about time that we woke up and understood the nuances of EGFR and EGFR, and understood that they were brothers being put in, or sisters being put in together, but they're not the same. And they have to be treated differently, each one at a time. And most certainly, Relay stands out in the results for exon 21, L858R, and the co-mutations. So thank you for the opportunity, and thank you, my panelists, Rupa and Ashish. Thank you so much.
Thank you, ma'am.
For engaging. Thank you.
Yeah, thank you, Dr. Sewanti. Thank you, Dr. Ashish, and thank you, Dr. Krupa Shankar. I would just like to sum up because Dr. Kumar couldn't attend right now. So the thing is that with the